All right, so this is our last week of lecture, and we're going to look at some specific pediatric emergencies. And again, within pediatrics, what I'm really interested in, other than the very top level of things such as knowing your dosage for epinephrine, for atropine, and knowing what to do in cases of cardiac arrest and ventilatory arrest. Uh, we're going to focus primarily in on the assessment and diagnosing of your patient as far as when things are going wrong. Kids are infection factories. They not only develop them, but they share them amongst each other like crazy. And so basically, we're looking at multiple different types of infections that kids can develop and transmit. These run the whole gamut from just a simple bacterial infection all the way up to a fungus or a parasite. Now, here's the good thing with kids: kids are really resilient, and most of the time they get sick and they get better, but not always. Some of the things that we're beginning to see, especially in the realm of respiratory diseases, is that these kids can really begin to suffer. And we've seen an uptick in the number of deaths of children who have had RSV, asthma, and pneumonia. And so this is a concerning thing to researchers out there as to exactly why this is going on. Within the realm of infections, the things that you need to know, both for your exam as well as when you're dealing with kids, is be very aware of the signs and symptoms of septic shock. Now, let's talk just a little bit because we'll talk a little more about this. What are we looking for in a pediatric patient with septic shock? Fever. What else? Tom. Pale. What else? Say it again. Tachycardia. What else?
Changes in behavior,
As a result of
altered mental status.
altered mental status, and that comes about as a result of decreased perfusion to the brain. Now, here's the thing to remember. All right, all of those symptoms that you gave me are correct. The flip side of those are also correct. So, a fever and then hypothermia as they get to final stages of this. Tachycardia and then bradycardia as they get to the final stages of this. So, again, as we see this whole process going through, it's important to realize that. With pneumonia, what are the two things that you need to know about that are most important? Not just two things, but what are the two most important things you need to know about in diagnosing pneumonia?
You're gonna have bronchi in the lungs and fever.
Bronchi in the lungs and fever, okay? With that bronchi, you will almost always have some type of a productive cough, but not always. If the bronchi is really thick, they're not going to get any of that out. So again, if you've got a child that is presenting with a fever and you're hearing that deep gurgling sound within there, now what we're looking at is we're thinking pneumonia. Meningitis. What are some of the hallmark symptoms of meningitis? So we have a nuchal rigidity. Basically, it's more so of a rigidity than a neck pain. Okay, headache, absolutely. Okay, I can remember when I was a kid, I had meningitis, and was probably one of the worst headaches I'd ever had in my entire life. But again, this hallmark symptom of nuchal rigidity, and the way that we check for that is we just simply ask the patient to put their head down on their chest. If they have trouble doing so, then that's a positive sign. What else are we looking for with meningitis? Bella?
Extreme sensitivity to light.
Photosensitivity, okay? Light really hurts. It makes that headache even worse. Very good. What else?
Fever.
Fever, okay? So we're going to see a fever. Now, a little bit later on in the lecture, we're going to dig down deeper into these. And in particular, we're going to look at a couple of signs that are going to be, I would like for you to know them because they are a little more sensitive to the indication of whether your patient has meningitis or not. Now, remember, how sick your kid is depends upon several things. Number one, it depends upon their immune system. Remember, very young children's immune systems are not developed really well, and so they can get very sick very quickly. As they go through, the other thing is the type of the type of infectious agent that is attacking the child, as well as how long the child has been sick. The longer the illness, the greater the possibility that this can turn into some type of a major life threat for our child. Again, because kids deal with respiratory issues, we are going to go back and we're going to review this whole process of respiratory emergencies. 3 things that you need to be able to identify in your patient. And as far as the identification goes, then there's the treatment. Number 1, respiratory distress, respiratory failure, and respiratory arrest. The transition between each one of those can be very, very subtle. But the thing to keep in mind is that in addition to looking at their respiratory symptoms, we're also going to begin watching their cardiac, in particular, cardiac rate, because as the rate begins to drop, particularly with a child, Tom, that has any type of respiratory problem, that is going to be an indicator of worsening respiratory status for our patient. Respiratory distress is basically your run-of-the-mill increased work of breathing, okay? They're compensating, but they're still having a little bit of trouble breathing. And this can come about by showing itself as far as an increased rate. And do you think as that rate goes up, is the tidal volume going to increase or decrease? It's going to decrease. Why?
They can't explain this right.
Yeah, so the other thing that comes into play here, you can't expand as much as a good reply. Again, fatigue comes into play, and this leads on into respiratory failure. So we want to address that as soon as we possibly can. When we're looking at these kids, again, in respiratory distress, quite often we'll get a decrease in their CO2 content. Why? Because they're breathing so fast that they're blowing off the CO2 that is within the lungs. So again, I would encourage you, do not be afraid that regardless of the age of your patient, any patient that's having a respiratory problem, go ahead and put end-tidal CO2 on them, because that's going to give you a ton of information very early so that you can kind of watch this and help prevent this from progressing on to a more serious type of condition. Remember, we're all really good about using pulse ox, but pulse ox tells us what happened 5 minutes ago. End-tidal tells us what happened 5 to 10 seconds ago. And so end-tidal is much more sensitive. They're both good tools. You should use both, but you need to know the limitations of each that we're looking at here. Now, in respiratory distress, when we begin to see that patient exhibit some altered mental status, now we're concerned about it transitioning from distress into failure. Remember, anxiety can be a type of altered mental status. This is why anxiety is such a subtle finding in your patients, because it could be because the sympathetic nervous system is on overload, especially in a pediatric patient. You come in, they got a lot of strangers in their house. Maybe they're afraid that they've done something wrong and they've brought this on themselves. Maybe they're afraid they're going to get in trouble with their parents. They're afraid of going to the hospital and anything that might involve. So they're anxious, which is a normal part, versus decreased cerebral perfusion and oxygenation, which would be a type of altered mental status. And the only way that you can tell the difference is by watching and assessing your patient over a continuum of time, okay? So now when we're looking at this, what we're doing then is we want to try to keep our patient we want to address the respiratory distress, but we definitely do not want them to move into respiratory failure. Now, basically, what's happening here is that the pulmonary system cannot bring in enough oxygen, and for a number of reasons, either increasing or decreasing respiratory rate, and most often decreasing tidal volume. Now we're seeing our oxygenation begin to drop and our CO2 retention beginning to go up. Again, in watching and comparing your pulse ox to end tidal CO2, you should see that pulse ox begin to come down as far as this percentage, but not nearly as quickly as what you would see end tidal begin to go up with retention of CO2. Again, the thing I want you to remember is that CO2 equals acid. Now, acid is not always a bad thing in the body. We need acid. We need alkaline solutions within the body to buffer ourselves and to keep our pH in that nice 7.35 to 7.45. The body has a tendency to like to reside on the acidic side of normal. That's not mean that they're acidotic, but it's within that 7.35, they're on the acidic side of that. But as the patient begins to progress now and they're retaining more CO2, now they become more acidotic. Now let's think about this for just a minute. What are some negatives of a patient who is now becoming acidotic from a holistic perspective in the body? What negative repercussions come about because of acidity in the body? For one real big one, think back to trauma and why we don't like to give normal saline.
Reduces coagulopathy.
Yeah. So in trauma, the more acidic your patient is, the more they're going to bleed. And so they're not going to be able to coagulate. Very good. What else? What happens to the vasculature when our patient becomes acidotic? Dilation or constriction? You got a 50-50 chance.
I think dilation.
I think you're right. So again, Tom, when we're looking at a patient that may be septic, why do we want to be really concerned about CO2 retention for this particular patient? They're going to decompensate faster. And remember, kids don't compensate for very long, for very well. So again, what we want to try to do is we want to try to maintain our patient in that nice 7.35, 7.45 range, because just like you said, if we've got trauma, they're going to continue to bleed. If the acidosis continues to increase, whether we've got trauma or not, if our patient is septic, and remember, pneumonia, meningitis, any type of respiratory disease, our patient can become septic. Now it runs into not only just a respiratory problem, but now we've got a vascular problem, and it's going to begin to drop down. All right. Now, ultimately, if we don't address respiratory failure, we're going to go into respiratory acidosis, and very quickly, our patient transitions into respiratory arrest. Understand this. Your patient can still have some minimal respiratory movement, minimal physical action of breathing, and still be considered in respiratory arrest. If your patient, say you got an 8-year-old and they're breathing 3-4 times a minute, that's not sufficient. That's not sufficient for us. That's definitely not sufficient for a pediatric patient. That patient is now considered to be in respiratory arrest, and you've got to jump in there and begin addressing that. So these are typically, as it's slowing down, these are called agonal respirations, much like we see when we talked about idioventricular rhythm in cardiology. What is an idioventricular rhythm?
Just a rhythm coming from the ventricles.
It's coming from the ventricles. Very good. Why? Because the atria have checked out. They're no longer functioning. So definitely it's coming from the ventricles. What else? Bella.
Widen QRS.
If they widen QRS, that helps us to confirm that it's coming from the ventricles because you got this really wide and bizarre. What else will you see? You guys are doing fine so far. What else will you see on your monitor that helps you identify idioventricular?
The rate is slow.
The rate is slow. How slow?
Like ventricular pacing.
Like ventricular slow. So it is 20 to 40. In the past, and I wish we'd get back to this because it's a good description of idioventricular, we called it a dying heart pattern. Your heart is in the process of just shutting down, but it's trying its best to maintain perfusion. So coming from the ventricles, wide QRS and very slow, but it's not enough perfusion. We see the exact same thing in the respiratory world. Respiratory rate begins to slow down. The rhythm of the respirations now can become very irregular, and your tidal volume will often become very deep. But because the rate is not adequate enough, now your patient is considered to be in respiratory arrest. Within these particular patients, again, these patients will almost always be unresponsive. Why? Because we're not getting enough blood that's going into the brain. So the best thing that we want to do here is we want to get in there and we want to be very aggressive in addressing this. So going back to respiratory distress, what are your steps that you're going to address and take care of in the pediatric patient? How are you going to deal with it?
Keep them calm. And I'll probably do a cannula.
All right. So I would tell you cannula would be fine as long as that's appropriate. Again, when you're doing your assessment of your patient, John, you want to assess the whole patient. So not only are we going to look at our pulse ox, not only are we going to look at our end-tidal CO2, but we're going to look at our patient's face as well. We're going to see, do they have that look of fear on their face? The work of breathing that's going on. So if your patient has got some retractions, Allie, I would tell you a nasal cannula is probably not going to help them a lot. Why? Because most of their air intake is going to come in by mouth. So go ahead and put them on a mask if they will tolerate it, okay? At what point do you decide then that oxygenation is not enough, but now you've got to add ventilation with a BVM?
When the rate is not adequate.
How do you know when the rate is not adequate?
How do they look? Are they getting super altered? Can they like support their respiratory efforts on their own? Or are they like
Okay, good start. What else? What are we going to be looking for? John? Mental status change. Remember, your mental status is the canary in the mine. Old days, they put canaries in the mines to check for methane gas because the canaries would stop singing and they would fall over dead long before it began to affect the miners. And so that was their warning system. Same way with you and I. We're going to watch our patient's mental status to look for early on subtle changes. Don't look for the big ones of where your patient is unresponsive and go, oh, now I got to do something. No, you're really late if you're looking at that. So look at those mental status changes. What else? Give me one more. These are two good assessment findings, but what else? Bill.
their skin?
Look at their skin, okay? Don't simply look for their skin to turn cyanotic. But if it becomes pale, that can also give you an indication that the patient's respiratory failure is worsening. Why? Because, as we already said, I think Tom said a while ago, we get vasodilation when the patient becomes acidotic. When we get vasodilation, now we begin to get shunning of blood away from the skin, and it leads into that pale skin. The other thing I would tell you to watch for is if your child begins to get sleepy or they get this head bobbing thing going on, now you're going to have to ventilate. And so you may actually have to RSI your patient. We'll work on that this summer. Or you will have to try to supplement ventilation with a BVM while the child is still partially awake. Questions on managing respiratory issues? Bacterial tracheitis. Bacterial tracheitis, but I'm not sure why I've got the same stuff, everything on the. Anyway, I will get you some additional information on this that'll fill in the last two slides. But bacterial tracheitis. Do a little bit of medical terminology. When we're talking about tracheitis, what are we talking about? Inflammation of the trachea. What can cause inflammation of the trachea? Don't worry about the title of the slide, but what are some things that can cause inflammation of the trachea?
Any kind of burns.
Say again? Burns.
Any kind of like infection.
Any kind of infection.
Excessive coughing.
Coughing. Any of those things can lead
Trauma.
trauma. Any trauma. Yeah. Definitely burns. Any trauma, particularly when we're talking about any trauma to the upper airway. So when we're looking at this, again, remember the inflammatory process in the respiratory system causes what that is so detrimental to our patient? As a result of what happening? Definitely obstruction, you're right, but why obstruction? Because of the swelling, okay? We'll talk a little bit about asthma here. We'll come up with the next slide. And with asthma, we know we get bronchoconstriction and we get inflammation, which is kind of a double whammy. So when we're talking about bacterial tracheitis, now that narrows that down even more so, coming from some type of a bacterial infection. When we're looking at a child that has bacterial tracheitis, okay, leading into that inflammatory process, what do you think would be one of the things that we would be most concerned about with a pediatric patient that has this?
Like the losing our airway.
Absolutely. Because remember, and the younger the child, the greater the concern that we have, because remember, the trachea is an hourglass shape, wider at the top, wider at the bottom, and really narrow in the middle. And so any of that inflammatory process can come into play there. And so many times when we're thinking about the trachea, we're only thinking about what we're able to see when we're going in to intubate. But remember, the trachea runs all the way down into the lungs. And that trachea of the pediatric patient is not only pliable, but it is very narrow. So when we begin to see edema that comes about as a result of the inflammatory process, now this is going to cause us some great concerns. What are some things that we can do? Now, obviously, the long-term solution for bacterial tracheitis is what? Say it again. Antibiotics, okay? As it stands right now, we're probably not going to be giving antibiotics unless y'all are going to be working in the ER. Many of you will be. But what can we do pre-hospital-wise to help to maintain an open and patent airway until we can get them to the hospital? Bill. This is one of the most important things that we can do for kids. especially starting at the beginning of winter and running through spring. If you guys do not carry humidified oxygen on your ambulances, you need to advocate, start with your medical director for the importance that you do that. A humidifier is not that expensive. Basically, it's a closed container of sterile water. And yes, there's a cost, but again, there's a cost to everything. And remember, cool, moist air will help to reduce swelling. And so that's exactly what happens in here. This is one of the reasons why we take patients with epiglottitis on the way out to the ambulance. We stop unless they're already in respiratory failure or arrest. We let them breathe in that cool, moist at night air to help to begin that whole cooling process. It's much like if you've got a sprain on your elbow or on your ankle. The treatment is to put ice on it. Why? Because ice cools it. It reduces the inflammation, it reduces the swelling, and it reduces the pain. So it will open up that airway. Question: will a bronchodilator be effective for patients with bacterial tracheitis? And be ready to defend your answer. Allie?
I'd say no, because a bronchodilator targets the bronchioles and the trachea is just too high.
Okay. Allie says no because of an anatomical reason. Anybody else got a different opinion or a differing? You may have the same answer as Allie, but for a different reason. What else? Y'all are a lot more fun on Wednesdays.
Her answer
It's
makes
okay.
sense to me.
Say it again.
I said her answer makes sense to me.
I agree. I feel like it would help. Well, no. This is tracheitis. No.
Would it be as effective as humidified oxygen? Be like the same thing.
So humidified oxygen would help to improve the soft tissue. But now remember, a bronchodilator does, and by the way, you were right, a bronchodilator does just that. It dilates the bronchioles. Now, why can bronchioles dilate and constrict? Think vascular. Say it again.
Because they're muscles.
Because they're muscles. Yeah. The trachea is not. The trachea is not. Okay. Even the fact that the trachea does not yet have those cricoid rings that go around them. And remember, the cricoid rings don't go all the way around. They're C-shaped, and they're basically as part of the protection for the interior part of the trachea. So the big thing that we're looking at here is that if we hear wheezing, then yeah, we would go ahead and give a bronchodilator, and it would open up the bronchioles. But a bronchodilator is probably never going to help a swollen trachea. The biggest thing that we can do here, as much as like Austin said, is that cool, moist, humidified oxygen is going to be the key thing for our patients. Okay.
Would Solumedrol or another steroid give any benefit to this patient?
I am a big proponent of us beginning to give steroids pre-hospital, but now keep in mind that steroid's probably not going to start working for another 3 to 5 hours. However, the latest research shows in patients with anaphylaxis or even with asthma, giving the steroid pre-hospital, and it's nothing magical about pre-hospital, but giving that steroid pre-hospital improves the patient's outcome, and they don't spend as much time in the hospital if they get admitted. So yes, I would tell you, unless you're dealing with a situation of what type of emergency, then you wouldn't want to give a steroid or start an IV at all. Pediatric what though? What type of disease? Epiglottitis. Again, the last thing we want is for the child to begin to cry. that epiglottis to now suddenly swell and becomes like a cork in a wine bottle. And now it's completely closed. Now, again, if a child crashes, then you got to go through that. So giving steroids, excellent idea for that. Questions about bacterial tracheitis? Yes, ma'am.
Go over like the symptoms of this, like 'cause I feel like a lot of them will be similar to other ones.
They will be. You're exactly right. So the symptoms that we're looking at, well, let me ask you a question. With bacterial tracheitis, if it's isolated bacterial tracheitis, only in the trachea, highly unlikely, but only in the trachea, what breath sound do you think you would hear? Stridor. Okay. You may hear a little bit of wheezing. Why? Because, again, you still have that passageway of the trachea for the air to go in and out of. So as it narrows down, now what we're going to do is we may pick up some wheezing, but most likely what you're going to do is you're going to hear stridor. Onset of a fever. Generally what will happen is the fever will begin to occur and then it will continue to increase. If the child is able to relate to you and speak to you, they will complain of a sore throat. In this particular situation, do you want to visualize the interior of the mouth or not? And tell me why for your answer.
I don't see a reason not to, and it could help you eliminate things such as strep throat.
Okay. Anybody else? Allie.
It depends on the status of the patient. Like if they're in distress or anything like that, you don't want to poke them from.
Okay. Anybody else? These are good answers. I'll tell you, they're both right. Okay. Again, let's go with your answer first, Allie. It depends on your patient. If the patient is very anxious, if they are crying, if you're concerned about the possibility that you would have something that would cause an occlusion, then don't do it. Now, understand the big thing that we're worried about here is epiglottitis, but also understand that epiglottitis is much more rare now than what it used to be because you can get a vaccine for that. If you do visualize the airway, it can help you to identify potential things such as like thrush, of where you would have some redness back here on the near the tonsillar area that would lead you into thinking, well, now it's actually more of an upper airway issue rather than a lower airway issue. So again, be ready to modify your assessment of this particular patient depending upon how they would present. Any other questions on bacterial tracheitis? Something that's really common and becoming more and more prevalent, that's asthma. Asthma is a long-term chronic inflammatory disease of the lower respiratory tract, the bronchioles, okay? The bronchi and the bronchioles. The thing that we're looking at here is that we want to identify asthma early, all right? And we begin to identify asthma early from both the history as well as the assessment of our patient. The key things that we're looking at here is that we have bronchospasm. And remember, the bronchioles are muscles, so they can constrict and they can dilate. The second thing that happens is we get an inflammatory process that goes on. And so not only does, again, a muscle can constrict or dilate, but it can swell as well. That makes the narrowing of that passageway even worse. And then the last thing that we see here is we get really, really thick mucus production that gets hung up into those bronchioles, and it blocks air coming in and out. Basically, the big issue with asthma, and I like to say that asthma is kind of like the old Eagles song. It's the Hotel California of respiratory diseases. Hotel California, the big thing was you can check in, but you can't check out. And asthma, it's easier to get air in. The resistance to the air coming in is much less than the air coming back out. What is the end result of that? air coming in, but we can't exhale it back out. Give me some details of what's going to happen to your patient. Tom.
They're gonna get tired because they're pushing.
They're going to get tired. They're going to get really, really fatigued again because of just what you said. Good. What else? Allie,
Increase in CO2.
we're going to see why. I thought we got lots of air in the lungs. Why are we going to see an increase of CO2?
You only can get air in and it's hard to get it out, so you're not pushing as much out as you're getting oxygen in, so it's the mismatch.
So let's think about this whole diffusionary process. Good answer, by the way. This whole diffusionary process of if we're getting air that's coming in, but it's not being able to be exhaled in exchange for new air. What is that? What impact will that have on the acidosis of our patient? And why? Go all the way back to your EMT class. Think again against perfusion of the alveoli, gray-black clusters, and the blood just cycling around those alveoli. If the air does not ever change in there, what's going to happen to our patient?
The gas can't diffuse in the alveoli, so acidosis is going to go up because they can't diffuse off that CO2.
So I will tell you, you're like 96% correct. But there is some gas diffusion taking place. What is it? What's the whole process of diffusion?
I guess oxygen being CO2 building up in there.
I'll say it one more time.
All the oxygen in there is getting converted to CO2.
So the oxygen is being depleted. But now again, diffusion means what? Just simple definition.
Like gas is like passing through the cell.
What else?
So, if it's not working correctly up here, so when you're perfusing around into your cells and your tissue, it's also mismatched because all you have left is CO2.
Now we're tracking. All right. Good job, ladies. Yeah, now we're tracking. So keep in mind that if we've got air that's trapped in here, initially we've got air, it's high in oxygen, picks it up, goes out to the cell, offloads that, and what does it pick up? CO2. It's coming back. Red blood cells are still high in CO2, low in oxygen. It's going to move that over into the alveoli. But eventually what's going to happen now is that in the alveoli, the oxygen content is going to be high in CO2 and low in oxygen. Diffusion still takes place regardless of what the gas is. So that higher pressure of CO2 is now going to diffuse back over into the red blood cell and come back out to the cell, which is going to speed up acidosis, which is going to speed up the change over to what? What type of metabolism? Anaerobic. And now things get, as my friend from Texas would say, more worser. Okay? Because now not only are we worried about CO2 changing into carbonic acid, now we're getting an increase in lactic acid and pyruvic acid, which now accelerates the death of the tissue. When cells become acidotic, they rupture, they blow open. And that leads to all kinds of problems for our patient, in particular the release of what electrolyte? Potassium. Okay? So again, you're going to want to watch these patients. It doesn't matter how young or how old your patient is. If they're having an asthma attack or a really severe respiratory problem, you need to put them on your monitor. Okay? Now, asthma can be triggered by a number of different things. Exercise, cold air, certain foods occasionally. Patients can get into an asthma attack as a result of stress. Certain medications, we know that aspirin can bring about an asthma attack. We know that beta blockers can bring about a type of an asthma attack again, so you want to kind of keep that in mind. The big thing that we see here is this whole release of histamine, all right? So when we're dealing with histamine, we know that it comes about and it causes bronchoconstriction. What is the other thing that many times we forget about in asthma, as far as that histamine release.
It causes those like leaky vessels, so fluid can escape the vasculature.
Leaky vessels and what else, Allie, from the vasculature?
For the vasculature, it's dilation.
Dilation. Yeah. So watch your patient's blood pressure as they struggle. And again, much like we said just a little bit ago when we were talking about acidosis, as the acidity goes up, vasodilation begins to increase as well. So you get into this particular vicious cycle. So what are they going to look like? Kids are going to be sitting upright. They're going to be tripoding. Quite often you will notice tracheal tugging at the base of the trachea, right up here into the sternal notch. If the child's got their shirt off, and if they don't have a lot of adipose tissue, you can begin to see some retractions that come in there. They'll cough a lot, but nothing will come up. Why? Because the mucus is so very thick. Again, this is another indication for humidified oxygen. Listen to your breath sounds, okay? You should hear wheezing, sometimes inspiratory, sometimes expiratory, sometimes both. But if you hear no air movement, that's known as a silent chest. Your patient is about that close to going into respiratory arrest. Why? Because the bronchioles are shut down so tight that there's still a little bit of air that's getting in and out because your patient's still awake. They may have an altered mental status, but at least they're still awake. But now you're not able to hear it with your stethoscope, even on a small child. Now, when we're looking at this, and again, put your patient on pulse oximetry, put them on end-tidal, make sure you're watching their blood pressure consistently as you're going through there, and monitor their heart rate. Allie.
This might be a silly question, but once they do go into arrest, does that like relax the bronchioles at all, or will it still be hard to hear?
So let's think about this for just a minute. Once they go into arrest, this is a good question, not a silly question. Once they go into arrest, what impact is that going to have on the bronchial constriction? Do you think it's going to relax it? Think it'll make it worse? Think it'll have no change at all? And then again, for whichever reason you choose, tell me your rationale why. Allie.
I think it will stay the same. Like when we already saw that patient at May, we couldn't ventilate her because she was so constricted.
Okay.
And Colby actually like pressed on her chest so they would expel that air. But
Okay.
I was just curious, like, is it going to be super hard to ventilate them regardless once we like lose that airway completely? So.
Yes, sir. Okay. Somebody else.
I think in the slightly longer term, the inflammation may go down some due to lack of cardiac activity,
Okay.
but it's not going to be enough to cause any positive benefit.
Okay. Anybody else?
I just like I couldn't ventilate this lady at all because she was so, even after we already saw her, like I was dumping on the back, could barely squeeze it.
See, this is why I like you guys. We get into these really high-level discussions. Bella?
I feel like you couldn't like oxygenate them a lot better because like the bronchioles are still going to be decreased at the end of the day, but maybe it might be easier to assist with ventilations, but it might not do anything.
So what you guys, all of you have said, there is an element of correctness to everything that's been said, okay? You already know. You are assigned this patient. You tried to ventilate her. It was tough going in. Why? Because her lungs were already full of air. Colby tried to provide some manual percussion to get the air out. In the short term, remember, what is the precipitating cause of this arrest in this particular patient? Bronchoconstriction. What makes bronchoconstriction worse? The same thing that causes vasodilation, and that's acidosis. when your patient is early on in a respiratory arrest situation, that bronchoconstriction is at the very least going to be maintained. It's not going to get better. Long term, basically after your patient has died, the muscle will begin to relax, like all muscles do, and it'll begin to open up. At that point in time, we're done. We're not going to be doing anything else. So again, even though you've RSI'd your patient, as you've already experienced, you're still going to have some trouble getting that air in. Yes?
So just to clarify, acidosis causes vasodilation but bronchoconstriction?
Yes. Yes. It makes that inflammatory process worse, especially if a bronchoconstriction is the precipitating cause. Yes?
So, but what do we, like, is there anything we can do at that point?
Squeeze hard.
Okay.
Squeeze hard. Here's the other thing you can do is that as quickly as you can. But now, let's think about this for a second. We can squeeze hard, or we can get our patient onto a mechanical ventilator. Now what are we worried about?
Causing more inflammation because of the pressure that we're adding.
So we can actually make the inflammatory process worse. You're exactly right, because we're squeezing, technical medical term, squishing. We're squeezing the tissue there. What else?
Like breath stacking?
Now, what's breath stacking?
Oh gosh, this is a cold question. Basically, like where the vent is just pushing it in, but like you're not expelling because it's so constricted.
Yeah, and so in breath stacking, that is a correct term, but basically what it means is that the pattern is full. You're not getting any more air in. But remember, as we try to increase the pressures in the alveoli, we run the risk of what happening? Barrel trauma, leading to a simple or a tension pneumothorax. Again, there's no real way of us knowing. Unfortunately, to my knowledge, there may be, those of you working in the hospital, find out for us, but I don't know of anything other than, say, like epinephrine, albuterol, Xopenex, that will relax the bronchial muscle itself. Maybe max sulfate would be something we come in, because max sulfate does relax muscles. That's why we give it to patients that are in severe respiratory distress, not so much with kids, but with adults, or for patients that are having eclampsia. So what do? First of all, we got to be really aggressive and jump in there and try to reverse that hypoxia. Okay, we got to get it turned around. All right. In this situation, what I would tell you to do, again, this is based on your protocol, but again, if your protocol doesn't include this, I would encourage you to go to your medical director and say, why? There's very little risk in giving a steroid to a patient who is having a bronchospasm as a result of asthma, because the inflammatory process is there. And again, like I said, the research currently shows that patients that get early steroids, even though they're not going to work for hours, actually have better outcomes. So, humidified oxygen helps to break up the mucus that's in there, to thin it out so that the patient can cough it out. The coolness of the humidified oxygen helps to reduce some of the inflammatory process that's going on. Giving a bronchodilator for your patient. And again, here's the thing to keep in mind. If you've got a patient that is in respiratory failure, how are you going to get that bronchodilator in when they can't breathe? What change are you going to have to do to get the bronchodilator into the bronchioles?
I guess you have to give it IV.
We might be able, but we don't give albuterol IV. We can give epi. We can give max sulfate. Yes. But what about?
Do it in line with the BPA versus
There you go. Excellent. So do it in line. Not so much with your CPAP, because remember, asthma is a contraindication to CPAP again because of the air trapping. But if you've got a BVM, okay, what you would do is you would take your nebulizer, put it in line between the bag and the mask, or if you've intubated your patient, between the bag and the tube, and you will squeeze that. Where would you expect to hear, let's say you got a patient that's severe asthma, no breath sounds, and now you're forcibly pushing albuterol into the bronchioles. Where do you think you would start to hear breath sounds first? Why?
I mean, hear it in upper lobes because that's where it's going to go first.
Yep, you're going to hear them up in here. You probably, while you're with the patient, will never hear breath sounds in the mid or the lower lobes of the lungs, okay? And we're okay with that. We're okay with that. So again, if your patient is not able to maintain consciousness, now what we got to do is still need to get that bronchodilator in, but we're going to have to push it in. Use it. Okay. All right. So now, a condition known as status asthmaticus. Status asthmaticus is a lengthy, prolonged asthma attack that is not broken by being really aggressive with your drugs, okay? In your patient, remember, what is the other status type of situation we're concerned about? Status epilepticus. Again, both of these, the big thing that we're really, really concerned about is the fact that during seizures, your patient doesn't breathe. Both of these can lead into severe brain damage that's coming about as a result of poor respiratory sufficiency. In this particular situation, your patient will be exhausted. They will often be unresponsive. This, John, is definitely going to be a situation where you're probably going to have to go with both BVM'd bronchodilator, but I would also tell you in this situation, you're really going to have to go up to epinephrine and mag sulfate, okay? I want you to know those dosages for your adult patients, but I also want you to be able to look them up and to know what you would go with for your pediatric patients. These patients are critical, okay? It sounds like maybe the patient that you had was a status asthmaticus patient because of the length of time that she had been breathing. What?
She was COPD masturbation really bad. Like,
Okay.
We were all shocked that she was that hard to annoy, like everybody.
Yeah. So again, just be really aggressive in dealing with these particular situations. Questions about asthma? Yes, ma'am. So let me ask you a question. So the question's a good one. Wouldn't it be easier to intubate these types of patients? The answer is maybe. And why would the answer be maybe? What does intubation not accomplish?
What does it not accomplish?
Mm-hmm. Say it again. Yeah, so there's no bronchodilations going on. Did you have something else you wanted?
Yeah, that's pretty much it.
Okay. So, yes.
I was going to say the same thing.
Okay. So we can get a tube into the trachea and we can increase the pressures that are going in because we can either BVM our patient or we can put them on a ventilator, but we're still not getting air in and out. Now, one of the benefits with intubation is that it is going to reduce a small bit of the resistance to getting a bronchodilator down into the bronchioles. So I think that would be your biggest benefit for that because you're still going to have the constriction that's going on. Anybody else? Okay.
What about if they can tolerate? I know it's different on children, but if they can tolerate it, BiPAP.
BiPAP and CPAP have a tendency to be contraindicated in asthma because of the air trapping.
Okay.
BiPAP would definitely be better than CPAP because we're only getting the air that's going in when they breathe in. But even with BiPAP, you got to be really, really careful that we're not making the situation worse. All right, good. Pneumonia. Okay, pneumonia is an infection of the lower airways. Pneumonia can be bacterial. Pneumonia can be viral. Pneumonia can be chemical. Give me an example of chemical pneumonia. Yeah. Ammonia is the exact. Okay, go ahead. Okay. We're glad you're here with us today. So yeah, any chemical that comes into the lungs can lead into inflammation and mucus production. Now, let me ask you a question. What would be the one thing that you would typically see with chemical pneumonia that you would not see with bacterial or viral? No fever. No fever. Okay. And again, what we're looking at here is we're going from the history. So if you've got a guy that's pulling ammonia trucks going out to a farm, if we get an ammonia leak, and I say ammonia because that's the one that's the most common. You get somebody that is cleaning commode. It used to be all the time that people would have a tendency to put Comet powder and bleach together to clean the commodes. Did a great job of cleaning, but it released ammonia or chlorine gas to come into the lungs. And again, so in that particular situation, you're going to still have the same signs and symptoms of pneumonia, but you're going to have a sudden onset and no fever. Now, again, pneumonia can be minimized, again, because there is a vaccine that is out there, and certain populations are suggested to take it. Generally, the vaccine is good for about 5 years, so it's not a yearly vaccine. So assess your patient if you suspect that they've had pneumonia to find out whether that they've had it. People who get pneumonia have a tendency to have concomitant diseases. They are diabetics. They are immunosuppressed. They have some type of cardiac disease that keeps their immune system at a very low area. With kids, most of the time it starts out as some type of just a regular cold, but it continues on and it begins to consolidate. And that's what the mucus does in a portion of the lungs. When you're listening to breath sounds, the rhonchi that you will hear will usually, remember, your patients haven't read your book, but John, usually it will be located in one part of the lung, and the rest of your breath sounds will be clear. So again, when you're listening, if you hear rhonchi here, and then you go over here to compare and you go, wait a minute, that's clear. Don't be surprised. That's perfectly normal. Okay? When you listen to your lower lobes, most of the time you'll hear some diminished sounds if you've got rhonchi up here, but they can be clear as well. That is known as consolidation. Remember, if I repeat things, it's not because I'm just old and forgetful, but it's probably going to be on an exam. The big issue with pneumonia is it leads into a condition that's known as atelectasis. Atelectasis is what?
Collapse of the heart.
What does not happen when we have atelectasis? There's no gas exchange, no gas diffusion. Okay. Now, atelectasis can be reversed, kind of. Many times, if you ever had surgery, you've had that stupid little machine that they give you, an incentive inspirometer with the stupid little balls. My last kidney transplant, they gave me one. I got bored and I turned it upside down. I tried to blow out to raise the balls up. My nurse was not impressed. But what you can do to reverse that is to encourage your patient to take as deep a breath as they possibly can. The things that we're looking for here with our patients that have pneumonia is that they're typically going to run a fever. Now, the bullet says you can run a low grade, but you can also run a high grade fever early on in this. They'll have a cough, and quite often the cough will be non-productive, okay? You listen to breath sounds, you hear rhonchi. You may hear some crackles elsewhere, but rhonchi is going to be there as well. The thing with pneumonia is your patient will be exhausted because their body is using up all of the ATP to try to fight off the bacteria or the virus most of the time that's causing the pneumonia. Yusuf.
You said that the cough is often non-productive.
It is often non-productive. Why? Yeah, so basically the stuff that is in there, it's kind of like, it's not concrete, but it's really thick. So it's difficult to get that out. And one of the things that they will often do is they'll put these patients on short-term humidified oxygen to try to thin that out somewhat. The other thing that can be done at home is to use a humidifier to breathe in. And then remember, the humidifier will put out cool, moist air that will bring that about. Sometimes parents will often try to take a teapot and warm up water to bring that in. There's a danger with that because remember, your tissues are already inflamed, they're very sensitive, so it does not take a really high temp to now cause some thermal burns to the pulmonary tissue. Yusuf. Okay? That's where we're going to stop for today. Guys, we will pick this up on Wednesday with septic shock. Any questions